a first for us. So if you, in the Zoom world, as Roger would say, can't hear, please let me know. We'll start it now.
Hello, my name is Luis Manriquez. I am an assistant clinical professor and a family doctor at the Lloyd College of Medicine, and I'm leading the work creating the mobile clinic. So this mobile clinic is, well, first let me start with WSU College of Medicine Community Medical School. We have 4 clinical campuses in their first 2 years in Spokane, and then they will go to either Vancouver, Everett, Tri-Cities, or Spokane for their clinical practice. The mobile clinics are part of the practice plan for the College of Medicine that is being developed, and we currently have funding to create these mobile clinics, particularly at using the Spokane area first. So this is the results of our needs assessment, which was put together this summer by myself and 3 medical students, Ashley Carly Celebrezzi, and Megan Olson. So I just want to go over our findings and then talk about how we could collaborate with providers in the North Central region. So here's how we went about the needs assessment. We had an online survey followed up by in-person phone interviews and group presentations. We also worked with the Spokane Alliance to identify needs specifically in the Spokane region. And then we looked at other needs assessments produced by the Washington Health Access Association. And so we partnered with the Spokane Alliance. Their work, they did listening sessions with their member institutions, churches, unions, community organizations, to get a sense of how they are, what needs they see. So we focused around the Spokane Clinical Campus. You can see there in yellow is the area that we focused on first. So those counties: Okanagan, Douglas, Grant, Adams, Lincoln, Spokane, Stevens Ferry, Monterey, and the Spokane, Kalispell, Colville, Port Lincoln tribes. I will talk about Chelan in a second, because I know that's part of the North Central ACH, but it was not initially part of the. So the way we went about this needs assessment, the people we were trying to talk to were our different stakeholder groups. We wanted to get a sense from multiple points in the community how we might be able to provide support with mobile clinics. So we talked to the Department of Health, the Extension Office, school districts, local government, medical providers, social service providers, community organizations. The responses that we had overall, and then I'll talk about each of the North Central counties individually. So we had 131 responses for an online survey. That online survey was sent out to people that we had identified and contact information for, and then we asked them to send it to anyone who might be interested in filling out the survey. So we don't have a complete assessment of all of these regions, and we're sort of dependent on the word of mouth along with that group partners like the ACHs or the health to make sure that they got it. So if it didn't get you, I apologize, but we are continuing. So anyway, to overview, 131 responses, followed by 34 phone interviews and 8 community presentations. This would be the 9th with the Health Coalition, actually, for the school. So what we found in Okanagan, we had 31 responses. This was the biggest response rate we had outside of Spokane County. Issues that they had found were services that were hard to meet, mental health, and treatment for alcohol, opiates, and other drugs, access to specialty care, and primary care across state. Leading preventive service gaps were substance use screening, dental screening, and diabetes eye care. And leading social determinants of health that were identified as contributing to health issues were housing, transportation, immigration status. Just an example of something we got from one of our phone responses. Okanagan is the largest county in the state, 5,200 square miles with mountain passes. It can take 2 hours from one end of the county to the other. It doesn't even include the people who choose to live off the main drag. We're not just rural, we're more here. I know the Colville Reservation covers Okanagan County. From Colville, we had 5 respondents. Primary barriers they saw were for the elderly population, access to care and immunizations. Hard to meet services they identified were dental care. Many respondents indicated this was an issue, particularly outside of areas where the clinics are. And then leading social determinants of health, again, housing, transportation, discrimination. Grant County had 9 respondents, plus we went to the Health Coalition meeting in Grant County. Issues they brought up, again, treatment for drugs, opiates, and other drugs, opiates, treatment, specialty care, mental health, and primary care for those over 18. I should say that other drugs essentially mean methamphetamine, because we asked about alcohol and opiates. Leading preventive service gaps, dental and substance use screening, leading social determinants of health, and these are pretty consistent throughout all the counties: housing, transportation, immigration. So in Grant County, demographic trends suggest that health inequalities in our growing county will continue to increase. The fact that our county is so large makes it difficult for folks living in remote areas of the county to access medical care. Mobile medicine could make a huge difference for some of our communities, bringing the care and education directly to them. And there was also noted the split between West and East County in terms of demographic. In Douglas, we had 5 respondents. Hard to meet services, dental, and I should say for dental, it's all for the adult Medicaid population. Those were the groups that had the biggest issues. Mental health, treatment for opiates, other drugs, alcohol abuse, leading preventive services, dental, substance use immunization, particularly HPV, social determinants, transportation, immigration status, housing, food, insurance. One of our respondents, this is what we heard, not our opinion, is that there's a discrepancy between what is offered and what is desired. Providers do not understand the culture of poverty and therefore do things like tell a client to use a humidifier when the client is in the garage. I did want to talk for a second about Chelan. Chelan was not originally included in the needs assessment service area. Having talked with the ACH, they asked that we include it, and so from that point forward, we did send out surveys to people in Chelan County, school districts, social services, and through the North Central ACH, it was sent out to providers. We did not have any responses. The way that we are actually going to go about incorporating Chelan, so these regions are part of the needs assessment, but in actual service area, it's likely that the east side of the county will be included in the Spokane area, the west side in the Everett service area, because those mountains make it very difficult to get there from Spokane in a timely manner. And then the South County may be included in the Tri-Cities service area, trying to really cover the valley and the communities, the makeup of those communities there. So there may be some changes in this map. Either way, we'll be doing more assessment of Chelan with the next round of the needs assessment, which should hopefully be the Tri-Cities area and hopefully this summer. And the mobile clinics, I should say, will have an integrated record. So it's not as if there won't be an ability to communicate. It's just going to be which unit based in which area is going to come out. And so that may be particularly important when we talk about the valley and the need for to prioritize providers and staff that speak Spanish. May make more sense for Wenatchee to be included in the Tri-Cities area, where there's more of a need for Spanish population and services. We can make sure we're addressing these directly. So just to give an overall picture of the entire needs assessment area, because we did find lots of things to be fairly, the problems in rural counties to be fairly consistent, I should say. So we broke up all of our responses by Spokane, by rural counties, which is all the counties minus Spokane, and then the total, so you can get a look at how those differed. So the first question we asked was around social determinants of health. Which issues are affecting people's access to health care or their health directly, but not through a healthcare mechanism? And overall, housing was the number one, and then transportation and insurance. Housing, transportation, and insurance were the big problems everywhere. It just mattered which order they were found in. That percentage there is that in Spokane, 73% of respondents had mentioned housing as a social determinant of health that affected health, and in rural areas, 88%. And these social determinants, in many cases, rural areas' response rate was a little bit lower. They pointed out less problems, except here in social determinants. So I think it's fair to say that transportation in particular was something that was widely and broadly felt, and that speaks to the value potentially of having a mobile clinic that can come to people where they are. Barriers to primary care was the next question we asked. There was no real difference between age groups, so there wasn't a difference between access for children versus adolescents versus the working age population or the Medicaid population. But the major barriers that were mentioned again were transportation costs and access for Medicaid patients in particular. But as you can see in Spokane rural and the total area, there's very little difference between working age adults, young adults, and infants and toddlers in rural communities, and in total there is a little bit less sense of need for infants and toddlers in Spokane. We also asked respondents what services were hard to meet, and if you combined substance abuse, so we asked about substance abuse as alcohol, opiates, or other drugs. If you combine those responses into one response around substance abuse, that would by far be the most needed treatment overall, and in both Spokane and rural results. So there was at least the perception that there is a lot of need for treatment of substance use across the region. In rural areas, mental health first, then opiates, then other drugs, and other drugs is essentially asking about methamphetamine. And then if you look overall, it's the same thing, mental health, other drugs, and opiates. They switch places, but they're essentially tied. So there was a little bit more concern for meth in the rural counties and then in Spokane, but they're essentially equivalent. We asked about barriers to immunization, and we were asking about age groups to see if there was one age group in particular that stood out for needs. When we asked about barriers to immunization, we actually had our lowest response rate, and we think that was for a couple of reasons. So when we look at the health department data and we look at how Washington compares to the national average, there are certainly we're certainly not doing fantastic in terms of immunizations. And so this low response rate, how did we explain that? And we think that many respondents didn't feel qualified to speak about immunization rates because many respondents were not actually healthcare providers, but as I said, were coming from education or the extension office or community members or local government. And so that's why we think these response rates were lower. In Spokane, infant and toddler need was greater, and that's probably because we talked to a lot of the early Head Start organizations. And in rural areas, sort of K through 8, infant, toddler, and adolescent, we're all kind of sharing as the top three needs. So preventive services, we asked them what preventive services were most lacking or hardest to address. And dental came out number one across all areas in terms of access. And this is, I should say, primarily for the Medicaid adult population. So there are services available and there are efforts to try to do referrals, but there's just more need than available for lots of reasons, what we've heard in terms of Medicaid population. After that, substance use disorders, both screening and treatment, were strongly needed across the region. The diabetes finding refers to an annual diabetic eye exam, and I suppose we could talk about a foot exam as well. So those dental, substance use disorder screening, and diabetes were the highest rated concerns in rural areas and also in as well. Some special considerations that were also brought up were family planning, reproductive health, and STI screening. So those issues, I think, were primarily focused around youth. So overall, recommendations that we had put together for the whole of our needs assessment for the board in determining how we're going to build out these mobile clinics. So the mobile clinics will need to go into the rural communities, not just to the biggest city within those counties, particularly through collaborations with schools. Everywhere we went, we asked what is the natural gathering place by which we could get to families and communities, and the schools were number one across all regions. It's going to be very important that these mobile clinics have an integrated EMR so that we can connect with existing providers in the communities and be a care extender and not duplicating services or, in some way competing for provision of services. The mobile clinic should not turn away anyone due to cost or insurance. So cost came up as a big issue, and it came up as a big issue both in terms of transportation to the clinic and co-pays and people who are uninsured. So trying to remove that barrier was one thing that we think would be valuable, particularly for low-income populations. Substance use screening and treatment are pressing healthcare gaps. So those are things that we need to make sure that we are addressing in some way through a mobile clinic, collaborating with local providers to address. And then mental health support is needed throughout the region. A couple more recommendations. Dental care for adults should be coordinated into clinic services. We are a medical school, but there's definitely a huge need for dental care, and so we need to figure out how we integrate oral health with the rest of the body. And then the clinic should be equipped to do diabetes eye exams. In lots of areas, the distance required to travel to get a diabetes eye exam was brought up as a reason why people weren't getting them. It's fairly easy to do that with a scanner that could be brought to a community center or so that was one of those recommendations. And then lastly, the clinic should help coordinate access to specialty care. And there are multiple ways we could go about doing that, but try to help people who may have a local PCP, but then if they wind up needing to go to the rheumatologist or the cardiologist, they wind up becoming patients of Spokane or patients of Wenatchee, and those distances become much more difficult. So that's all of our recommendations. I did want to talk for a minute about next steps, and then hopefully we'll be able to have some questions and comments and feedback from you all. So next steps, we have to build out these mobile clinics. We're awaiting some board and institutional decisions to help launch the practice plan, which will allow us to spend the grant funding that we have to build these clinics. So I do not have a direct timeline for when those clinics will be built, but our goal is to have them up and running at the beginning of the next academic year, which would be in August of 2019. We need to establish our integrated medical records. So we do have an innovation center at the College of Medicine, and there are multiple technological solutions to integrate whatever medical record we are using at the college with local records so that we can transfer information back and forth. And we also need to work on developing collaboration agreements with community partners so that it's clear what role we're providing and what pieces, how we can plug back into existing medical services in the regions, and then developing the clinical calendar and schedule and connecting those logistics. So, in terms of services that we're intending to provide, we are awaiting final plans on the outline of services from the board and the dean, so I cannot make any guarantees, but the areas of focus more generally will be that we are able to take care of urgent care needs, that we provide preventive health screenings, so the diabetic eye exams, foot exams, potentially blood child checks, immunization, reproductive health screening, and like blood pressure. Then dental screen and referral. So the need for dental care could be addressed through potentially building a dedicated dental unit. The decision about when we could do that and to what extent we can develop that unit still needs to be made. But at a minimum, we will be developing the capacity to do good oral health exam screens and referral to local providers, working with our Cora Foundation to make sure that we're plugging people into dental health. And then lastly, the ability to address mental health and substance abuse. So we have quite a robust research department at WSU around substance use and mental health, and we're looking at several different funding opportunities to provide telehealth and support services for the treatment of both mental health and substance abuse at the local level. So, it's not possible or useful for a mobile clinic to come in and provide counseling, once a month, or talking to people about their substance abuse once a month. But how can we use the resources of the university to support and back up what's going on locally? And so, we are working on developing those plans. Would love to hear from you all how that might most usefully be deployed. And that leads me to the collaboration with local providers for the mobile clinic. So while we're awaiting our final plans, I did want to give you a little bit of an outline of the collaboration. And this is what I'd really love to hear from you today. So our goals are making sure that we're extending services to patients, and the patients who are not coming to clinic for whatever reason, be it transportation, be it lack of knowledge, be it having to work, etc. So how can we reach those people and then plug them back into the primary care system that is already established in the local communities? That's going to, like I said, require an integrated EMR so that we can hand off to local care and potentially for reimbursement mechanisms. So in terms of reimbursement or sustainability funding to keep the mobile clinics running, there's multiple options we've been looking at. I wanted to give a couple of examples. So when we talked to Lincoln County Hospital, they thought the easiest thing to be would be for the provider on the mobile clinic to just be credentialed as a provider with the Lincoln County Hospital system. Therefore, whenever we saw a patient, it would be just as if a Lincoln County provider saw that patient. They could bill through their system, and there might be some reimbursement for the service provided, but that it would all kind of stay in Lincoln County's system. Talking to Chaz in Spokane and some of the other, we think this would be equivalent for other community health centers. They thought that would be more difficult to try to enroll as a provider with a health center. And so they thought the best thing to do would be to be a contracted service for the clinic. So we could look at utilization, how many Chaz patients have we seen, what services we provide. We could look at over the time and we could say, okay, that is worth so much money, and then that will just be funds that help keep the mobile clinic going. A similar model was discussed with Molina, where we would have contracted services by the MCO. So for every diabetic eye exam that we're doing, that's helping the primary care provider meet their metrics. It's also helping the MCOs meet their metrics and the ACHs meet their metrics. So that's a service that's helpful, and so to keep that service running is their service. Molina actually has developed its own mobile clinic for the purposes of helping meet those care gaps, and they find it to be working very well in Spokane. They're interested in having us provide that service other places for their Molina members, and we will be talking to other MCOs about that as decisions firm up the board. The last thing I wanted to mention in terms of collaboration is an extension office program. So there have been calls across the country for, we should do for medicine what we did for agriculture with the extension offices as a way to make sure that resources are getting out to rural areas, that those rural providers are supported by university institutions. There are several states that have done this quite well, including New Mexico and Minnesota. And so the idea here would be, talking with extension offices about having a health officer. We talked with Jack Davies about this from the rural hospitals. And a health officer in each county would help us know in Spokane what is going on, what are the needs, what are the barriers being met, would help direct the provision of services for those mobile clinics, provide a liaison by which we're in the community and aware of medical care needs, student education opportunities, collaboration opportunities. So that's one idea, and I'd love to hear what you all think about that. So I will leave it at that, and hopefully we'll be able to have a good discussion when I'm able to join you on the phone. I appreciate your accommodating this mixed method conversation. All right, thank you.
Okay, Dr. Manriquez, is that you? I see coming online.
It is.
Great. And for those in your room, if you have a question, I just know we did mute all your mics. Make sure you turn your mic on. We'll turn it over to you. You're sideways, just so you know.
Oh, am I?
Yeah.
Let's see if I can get that straightened out.
All
right,
there you go. Excellent. All right, I'll turn it over to you and then open it up for questions.
Sure, great. So any questions I can answer, clarifications?
This is David Olson. I'm with Columbia Valley Community Health, one of the community health centers in the area. We have already, we're finishing a process that started about a year ago. We are going to purchase a mobile clinic in April. It's my understanding that Family Health Centers up in Okanagan County is also moving towards a mobile service. And my question is there any way for our organizations and the School of Medicine to maybe work out some kind of, I don't know what the relationship should be, but I'd hate for you guys to spend money to do something when two other mobile services are coming out here. I'd much rather partner or collaborate. Is that something you can see happening?
Yeah, I think absolutely. I mean, we're planning on collaborating with Melina, and Chaz has already shown interest in sort of a shared staffing model where they might want to have some of their providers on the unit when we're in areas where Chaz patients are being seen. So I'd be happy to talk with you more about that. That's actually the first time that's come up. I know Yakima Valley Farm Workers Co-op has units, but they're all in the dental area right now. So I'd be happy to talk with you more about that. And sorry, could I get your? I didn't get a chance to write down your name.
Well, it's David Olson, but I've got your information and I can send you an email.
Perfect.
Thank you.
This is Sheila. Hi, I'm Sheila Chilson. I'm one of the other CEOs for the community health centers. And I think it would be good as you proceed if maybe we could have a conversation as all community health centers in North Central Washington. Just continuing on David's comment there, but I was hoping you could talk a little bit more about the integrated EMR, what your thoughts were on that. You know, what conversations have been held on that issue?
Sure. So our goal with the integrated EMR is essentially to be able to make sure that information is getting over to was one of two things. Either we can just have access to multiple EMRs, and then depending on how things are set up, we can document in whatever local provider's EMR they have, or using the one that we have, which will likely be Epic, how we can port those things over. And there are some third-party softwares that are designed for making those connections, and so that's what we would look into more in terms of how to make those things speak to each other and how to make that more than just faxing over things that has to be scanned in. What is the EMR you currently have?
We're on Simplicity. I know that there's just so many throughout this region. That's why I posed the question. You know, from Epic to Athena to Simplicity to just a multitude. So.
Yeah, so it's our understanding that there are some of the people that were on the Epic development team left with Epic's blessing to create this third-party connecting system software, which I'd have to look up. But our tech center at WSU felt pretty confident that we could make those connections as long as there's data people on either end to link it up. It should be quite doable. So that's what we're looking at, the integrated EMR. I don't know if you've had any success or frustration trying to do that in the past.
That's a whole topic in and of itself.
Got a couple questions. Actually, that's wonderful, wonderful thought, but it raises a lot of questions. I'm Jill Thompson. I'm from Lakeshland Clinic, but I also live in Waterville, which is a Douglas County small community. So, looking at when you talk about the health officers at the WSU Extension, is that coordinated with the Agriculture Extension? Is that what you're talking about on that?
Yeah. So I think Colorado and New Mexico collaborate on their program. The New Mexico program is called HERO, and Health Equity Resource Officer, or sorry, Healthcare Extension Resource Officer, and they are similar to the ag program. Their goal is to basically know what's going on in the local county, and then what information or supports can go back and forth from the academic health center. It's a little different in New Mexico because it's University of New Mexico Health Sciences, so they have their own hospital. We're a community-based medical school, so we don't have the same infrastructure as a healthcare system. But that's the idea that we're pursuing with the extension offices. So those conversations are still kind of early, but there's a lot of interest on both sides figuring it out.
What kind of licensure do the health officers have? Are those doctors, nurses, some sort of?
I think there are different levels of, and they're not doctors, but I think there are different levels of providers. I don't think all of them are even practitioners in New Mexico.
Yeah. The other question I had was about patient finding. Are you going to be seeking patients from Molina that aren't getting their care in a local way, or are you going to be just being out there and advertising, come see us when we're in town?
Mm-hmm. So I think that we're quite flexible on how we pursue that in each region, and I think that the bottom line is that from Spokane, it's not possible for us to understand the needs of all the different communities and then schedule meaningfully to show up and provide care. And so the best scenario is for local providers, for local community organizations to be able to direct that care and make sure that it's being done in a way that's useful. And so, that could be from the schools or from churches or from local community health centers, or the food banks or whoever it might be useful to make that connection. I will say that when we talked to the Rural School Nurses Association, they were very excited about the idea about having mobile clinics potentially coming back with their schools, but what gave them pause was the idea of having to add that organization and outreach and scheduling onto their already quite threadbare capacity. And so, that's one of the areas in which it might be really helpful to have someone whose role is to help make those connections. That's the idea of the health officer. That's one of the things they could be helping to do.
I think we have time for about one more question, then we'll have to wrap up. Can you turn your microphone on? Sorry. At the bottom. There you go.
Okay. Just one quick clarification on how our van in Spokane works, because it is everything Dr. Manriquez mentioned. But we also do for the gaps in care operation, we actually reach out to members. So we mail out to the members we have and try to connect with them every time the van will be in a specific location. And those members are selected from our gaps in care reporting, which says, show me Molina members that have not received this screening in the last 12 months. And that is the way we try to get to the rural areas for our medics.
Melody has one last question.
I'm actually commenting on behalf of Dr. Wallace. He could get through on the line. Just a couple of things. He wanted to make sure that maybe we can get contact information. There's several things that are really exciting to to see how this could fit into some of the initiatives that we're doing for family health centers currently. One of those is to make sure that we're incorporating in our behavioral health integration into this program as an extension of what we're trying to do as an organization. And the other thing, well, one thing that piqued my interest is because I've been working with Roger on the impanelment issue. I think that's going to be an important factor as we're reaching out to these patients, that we move that into an impanelment opportunity for our patients. And then the last thing is Dr. Wallace is really committed to student interaction within our organization. If this is something that we could work on, a collaboration that would also be an extension of the school from the mobile units into our organization, so that it's a truly collaborative effort. That's something he's really excited about.
Great. So I think are you talking about health science students?
Yep.
Okay. Yeah, so our goal, so in all of the things that the WSU practice plan intends to do, it's an opportunity for education. So we would expect that there will be medical students, if not also potentially nursing and pharmacy, coming out with the unit, so that they're getting exposure to a different model of care and to rural areas, and seeing, just getting that exposure and seeing who else has that connection. So that's definitely something that would be going on with the unit. And then the broader picture of it, where we are in the Office of Academic Community Partnerships, making, getting MOU agreements with different partners across the state for preceptorships in the first 2 years, for clerkships in the third year, and for either required, there's an urban or rural requirement in the fourth year rotation, or elective rotation in the fourth year. So there are definitely opportunities to connect more around medical education. And I think, as I said before, as a community medical school, we are actually dependent on engagement with local partners. And so it's something that we're putting a lot of focus and effort and attention to, and we'd be happy to follow up about the opportunities around those connections. In terms of contact information, the easiest way to get a hold of me is Luis, Luis, Manriquez, Manriquez, @wsu.edu.
Family Health Centers just has acquired a dental mobile unit that's just within the last few weeks.
Great.
So that may be something we want to talk about sooner rather than later.
Mhm.
And then the goal is to have a primary care mobile unit also within the next 6 to 10 months probably. So the timing is fantastic.
Great. Yeah, that's great.
Great. Well, thank
I
you.
know.
I'm sorry. I'm going to have to wrap up because we have our governing board meeting coming in
Sure.
afterwards. But I thank you for sending out your email address, and I can send it over the listserv as well to everyone, for those who were not here, so they would have it as well. I appreciate you joining us. Thank you for taking the time to do the presentation via PowerPoint and recording to accommodate your hospital schedule as well.
Great. Yeah, thank you for the time. Sorry I couldn't be there in person. Thanks for accommodating this next thing, and I look forward to talking to you in the future.
Great. Thank you very much.
All right. Take care.
One last thing to wrap up is just to let everyone know that our next meeting in March is up at Family Health Centers in